Alright, what's going on everybody? Welcome to yet another online lecture here. Unfortunately not everyone's going to be able to attend on a Sunday. Adrian I think is going to be on a clinical, so just make it nice and easy for everyone. There's positive feedback where people enjoyed that they could go back in the video and just kind of look over notes again, and some people are just auditory learners. So we're going to start with, of course, chapter 1. There's really not much to it. I think really the only thing is understanding our penetrating trauma, our blunt trauma. These are very easy to discern from each other. One thing that is going to be super important is this new drug that gets introduced in this chapter. It's going to be TXA, tranexamic acid. Our dosage is going to be a full 1 gram, or it might be labeled on your vial as 1,000 milligrams. You're going to take that, inject it into a 100 ml bag, and drip over 10 minutes. Yeah, if you have a 60 set or a 15 on the truck, you'll probably find it in a 15 drop set, so you can take our daddy and daughter doing the tango conversion or equation here. So we'll take our 100 ml because that's going to be somewhat of our dosage, times that by a 15 drop set. We have 1500, and then we're going to be dividing that by 10 for our 10 minutes titration. And 150 drops a minute, we divide that, that's going to be 2.5 drops a second, so essentially wide open, and go ahead and run it. This drug is going to be radio contact only, so you are going to have to get medical direction for this drug to administer. Keep in mind, anything after 4 hours of trauma or after the incident, it is not indicated. We do have different levels here for our trauma center designations. Typically in our area, everything is going to be a level 1 trauma. They're going to be suited for everything, neuro, respiratory, ophthalmology, who knows. And as it teeters down, you can kind of see that your level of care or expertise will somewhat go down. And then, of course, level 5, which isn't listed here, but you have fair lanes and just places of business you can put on ESO. They're literally dog shit. Keep in mind with some of our injuries, some patients may benefit with going to neuro centers. Of course, burn centers and pediatric trauma care centers are going to be super important. Burn centers and hyperbaric chambers will go kind of hand in hand. Other than that, this is going to be all very simple review for stuff we've already learned in EMT. Just keep in mind our GCS is going to be very important. Just know how to read it if you're presented with a question, how to correctly determine a GCS on some of these patients. The golden hour is going to be a period of the incident. So incident happens, and for the best possible outcome, you want within 1 hour to, let's say a patient breaks their femur, get them to a proper facility for further care and treatment within that hour or so. Other than that, there's going to be trauma triage criteria. You can go ahead and look over this, pause the video if you need to. It's more so of just review. So yeah, that is chapter 1. Not too much in it, but we'll move on to chapter 2. So this could be all mechanism of injury. I don't believe that there's going to be too many questions on our exam, or at least natural registry, that they're going to ask you some of this stuff. It's really going outside of our scope with, calculating our inertia or force that's going to be transferred. Just know that energy cannot be dissipated. It only transfers into another form or medium. So like in a car accident, the car impacts a tree, and that force gets applied to the tree, and as well something like inertia, we keep moving as the car stops. So there's going to be a lot of like secondary or tertiary injuries that come about with a lot of traumas. Common mechanisms is we have falls, MVAs, motor vehicle crashes, bicycle. Just understand the type of impact. So we have frontal, lateral, oblique, rear end, stuff like this. Just understand that where your body will be going in that event of impact. So if we have a frontal, just be susceptible to things like head trauma, cervical fractures, and when we have these laterals, just anticipate, extremity or, you know, uh, j- j- just get a rough idea of what might happen. We have restraint systems. That's pretty cool. We have our different pathways. So with our different impacts, so we can have with our frontals, intra-abdominal injuries, hip dislocations, rib fractures. Don't isolate just these, like a rib fracture, only with a restrained pathway. Um, just be understanding that all of these may happen, but these are going to be the most commonly that you see. Axial loading is going to be a pretty big topic. This is going to be like a compression injury. So you have so much axial loading, so you're loading so much weight on your spine and with those intercalated discs that you do end up to see maybe herniation of the disc or actual incomplete fractures or maybe a full fracture. Ejection, imagine. Um, Here's that. I believe this is the axial loading. Well, at least if we have a fall where a victim lands on his feet, there's going to be that energy exchange. So we're coming down, and that energy is going to be transferred right back up to the top of the body until it's dissipated. So we'll see compression fractures. Exsanguination is going to be a new term. This should be blood loss that's great enough to cause death. So with our, I wonder if I can draw on this. I haven't used this app yet. I just started using it because of the laser pointer. Oh, here we go. With trauma now, it's going to be XABC. That looks horrible. So, just remember that. Explosions is going to be our primary, or our first mechanism of injury. Most of the time is just going to be that over pressurized wave that's going to come towards the body. So that explosion is actually going to damage air-filled body spaces very easily. So we have the ear, sinuses, bowel, lungs. Just be susceptible to the fact that the tympanic membrane, which helps us hear and equalize that pressure, it can become ruptured. You can have lung rupture, bowel rupture, and not so much just sinuses, but these big three. Here we have our lungs in a blast injury. So with enough pressure, we can actually damage our alveolar walls. And what this will do with the extreme pressure is we're going to have inflammation, response, fluid accumulation, hemorrhage possible, and it may even throw a air emboli. Really big finding, I would say, is hemoptysis. So this is actually going to be the presence of coughing up blood. We do also have crackles, dyspnea, and altered mental status, maybe due to that air emboli. But these three are going to be super critical on finding if you have a blast injury and you find any three of these, start driving to the hospital. So treatment here is going to be ventilations. Just be careful. This may encourage an air emboli to form or exacerbate. If we do have evidence of that, lay your patient on the left lateral recumbent and then continue to bag them. This will discourage the emboli from traveling up the carotid and kind of lessen that pressure from building up. Um, Sepsis is pretty big. We all know how to do sepsis alert. You have your hypotension, tachycardia, tachypnea, their pyretic, altered mental status, um, and then evidence of leukocytosis, which is going to be just a fancy term of saying an elevated white blood cell count. Um, okay, I swear to God, I thought I saw sepsis on here. Sports injuries. Sorry. Uh, okay, well, there's sepsis, just in case you didn't know. Sports injuries are pretty common. Crush injuries are going to be pretty big in our trauma review here. So this is going to be pretty big. So something we can go over is compartment syndrome. So this is going to be a transverse section of the leg. So we have our tibia and then we have our fibia right here. And with these crush injuries or compartment syndrome, let's say you fuck this compartment up right here. So you can see how they're all subcategorized. This will actually cause the inflammation to build up, and so we have an increase in permeability. We have a fluid shift that moves outside of the vascular space into interstitial space, and we get even a release of histamine, and this starts pocketing up, let's just say with generic fluid, right? With this enclosed space, we can think of it as almost our cranial vault, that it will only allow for so much expansion. When we do that, we have blood vessels like right here that are trying to perfuse through it, but if we start snipping through them and we start occluding them, you'll start losing perfusion. You're not going to have oxygen exchange. You're not going to have proper CO2 delivery back out of the lungs. And then you'll also have a shift of or into anaerobic metabolism, because you're not getting that Krebs cycle. It's not getting the energy or the oxygen it needs to complete that. So we're going to be going down from 36 ATP down to 2 ATP. You're going to have an acidosis buildup, tissue necrosis, of course, because nothing's getting perfused. And with that acidosis, which we'll talk about in a second, some of the components will cause cardiac arrhythmias and kidney injury or heart injury as well. Treatment of this is going to be sodium bicarb. This is going to help allow us to do that buffer system and negate all of that toxic acidosis. So this is going to be evidence in crush injuries. So here we have our compartment syndrome, blunt trauma, pressure within the compartments, additional muscle will be damaged. So just be understanding that when we have that super huge increase in the compartment, we have blood vessels get occluded and tissues start dying. We have our penetrating trauma. Of course, it's penetrating. So we have our velocities. We have low velocity, so blades, knives, swords. If you happen to be in England, you'll see these pretty commonly. Bullets are going to be our medium velocity, and then our high velocity is going to be rifles. The more mass or the more fast it's going, whatever it may be, you're going to have a higher energy output. So of course, if we have two bullets, let's say they both weigh 10 grams and one's traveling at 60 meters per second and the other one is moving at 120 meters per second, the one with the higher speed is going to be doing more damage, of course. And then as well as mass. So these two are interchangeable. Here we have with our injuries, we have our cavity that's created. So this can be our zone of injury, of course. And when these things come into contact with the flesh or anything really, there's going to be a pressure wave. And that pressure wave is just going to start expanding and releasing all its energy into tissue that it comes in contact with. This is going to be, so that temporary cavity will also be referred as cavitation. Solid organs, if you didn't already know, liver, pancreas, brain, spleen, and the kidneys. Hollow organs, we have our intestines, stomach, urinary bladder, and our heart. Something to keep in mind with these hollow organs. So they do fill up with fluid or contents. The more filled up they are, pretty commonly in the urinary bladder, the higher chance of rupturing is. The more full they are, the higher chance of they are becoming ruptured. Hopefully we all know about pericardial tamponade. So we have our Beck's triad. So we have our muffled heart sounds. We have our hypotension, tachycardia, PR depression, low voltage, stuff like that. And distended neck veins, or JVD. Bullet may cause a pneumo. We should be able, or we should all know how to take care of a pneumothorax and how to justify or assess which one are we dealing with. Yeah, chest wounds, of course, we're going to use an occlusive dressing and needle decompress as needed. If you need to, let's say we have an open pneumo, before we go into the needle decompression, because it's going to be kind of pointless, why stab the patient twice, or, you know, why even stab them to begin with? If we do have evidence of a tension developing, just burp your occlusive dressing and apply it back on. So some of these things like our crush injuries, compartment syndrome, and chest wounds will be covered in the next one. So yeah, that's gonna be for the first two chapters. On to chapter 3. So it's slowly progressing into a little bit more here. Got a lot to cover. So we have hemorrhage and shock. Let's see. See if I'll split it up in the next one. Now we can do this one really quick. So shock is going to be a state of inadequate perfusion. Homeostasis is going to be the body's tendency to maintain a stable environment for the body to survive. Hemorrhage, you're losing blood. The heart is going to be referred to as the pump. We have a stroke volume. This is going to be the amount of blood that's ejected, which each heartbeat. If we take our stroke volume and we take our heart rate, you'll have your cardiac output. A big factor with blood in general is going to be the Frank-Starling's law. So this is going to be indicative. The more filling you have within your ventricle for the blood, the harder the contraction is going to be. If you're not perfusing as well, or you don't have enough blood, you're going to have a smaller contraction. Average pump is about 70 BPM. Average milliliters of blood is going to be 70. So nice, easy numbers. The heart is the most important organ in the body. If anybody cares to disagree, I do not care. You are wrong. We have 3 types of vessels here. So the way it'll travel, so as soon as we leave the heart, we're going to be entering through the arteries. So we have our aortic arch, and it goes through your clavicle, and then one goes up to your brain, and they split off. So we have our arteries, then they'll go down into our arterioles. Then these will transverse into our capillaries, and they'll have an exchange, and this is considered our microcirculation. Very small capillaries, or pipes. And then we'll go to our veins, and then this vein will come back into the heart and right around here. So we have our nice pretty heart, and then it'll go back through. Arteries are going to carry this nice rich O2 blood. If let's say we do have an arterial bleed, it's going to present with super bright red blood, and it's going to be often spurting just because of that systolic pressure that the heart is pumping it through. One thing that we will have to calculate to ensure that our patient is perfusing is MAP, which is going to be our mean arterial pressure. our equation that we can use is 2 dads plus 1 son equals a 3-person family. So we'll take 2 dads, or our diastolic, plus 1 systolic, and divide by that 3, and we'll get a map of whatever it may be if we plug the numbers in. So if we do that, let's say we have, let's do 134. So this is going to be our systolic. Let's say over 80, so 160. So 294, divide that by 3. We have a map of 96. So things that are really important is understanding that if our map is under 65, we are actually hyperperfusing. So we're losing perfusion to first, it's going to be our brain and as well as our kidneys. So let's say we are 40 times 2. So this is going to be our diastolic. And we'll say our systolic is 80. 160, divide that by 3. So it's going to be a map of 53. Severely hypotensive. They're going to need a fluid challenge. Capillaries, these are going to be the connections between the atrials and venules. This is going to be allowing diffusion of O2 and metabolic byproducts to exchange to where they need to be. What's super cool about this is how thin these can actually get. 1 cell thick, which is absolutely crazy. So like it's amazing that things can get that small. Yeah, amazing. Net filtration, just fluid movement in and out of a capillary. Actually, what's super interesting, so you often hear the blood-brain barrier. So the reason why some things won't actually travel across that barrier is because of the thickness of their walls. So they will only allow partial materials that are able to fit through that net filtration system to actually go through to the brain, which is super cool. The book really does not do a good job on explaining the blood-brain barrier, or does it even care? Veins, low to blood, we already know this stuff. Yeah. Just know that when we are in the hypovolemic states, in our posterior pituitary gland, you're going to get a release of, nope, I believe actually anterior pituitary gland, you're going to get a release of ADH, which is antidiuretic hormone. It's just gonna conserve all of that fluid the best it can. So you're gonna, easily you're gonna have less urine output. Blood contains this stuff. It's pretty cool. Transports this stuff. Pretty cool. Here's all the functions. So red blood cells are going to be commonly called as erythrocytes. Just keep in mind that these will be transporting our O2. These also contain a hemoglobin, which can carry 4 units of O2. White blood cells will be commonly called as leukocytes. So if we have, let's say, someone with sepsis or an infection, pretty cool term that they might be using is with leukocytes. The finding of leukocytosis will tell you that there is elevated white blood cell count. So if you ever hear that, just put those two together. If we have a laceration capillary, it's going to be bright red, but it's going to be oozing. It's going to be bright red due to that high O2 exchange that's happening. Venous, dark, slow, arterial, bright, spurting. Stasis is just going to be our body's way of just keeping everything tight. So this is our, let's say we have a little lac here. It's going to go through the vascular phase, platelet phase, and coagulation phase. Yeah, if you want to pause the video and read these, go for it, but I'm not going to go over this. I fucking hate this. Just know that body clots and it does its job when it needs to. So some things that can affect our homeostasis is movement. So if we just rip off a scab while it's healing, aggressive fluid therapy, which is pretty important. So when we do end up, like let's say we do a pressure bag, you're actually going to be raising that intravascular pressure, and it may actually pop out those clots and just push them away, as well as you might be diluting them. And this will just decrease carrying capacity of O2. Low body temp, everything gets a little bit slower, molecules aren't moving as fast. It's kind of like if you were to run in the summer, like your bones and joints, they're nice and loose, but in the winter you tend to move a little slower because you're trying to conserve heat, and your joints just don't want to be doing that. We got some medications, ASA, heparin, warfarin, Plavix, Lovenox is going to be our blood thinners, not so much as aspirin, but if you see these, just know that we're going to have a inhibition of clotting. External hemorrhage, direct pressure, of course, tourniquet if we need to, high and tight, mark the time. And when we do have an absence of perfusion, so these are going to be some things that we see in our crush injuries. We're going to have a buildup of lactic acid, potassium, and anaerobic metabolites. Yeah. Internal hemorrhage. So this we're actually going to be seeing with our TXA coming back here. So one thing that can contain a lot of fluid is going to be our abdominal cavity. It can carry a lot. Just know long bone fractures can also lose plenty of blood. Yeah. So if we do have internal injuries, of course we're going to call medical control, ask for TXA, give them the rundown of what we got, and they will approve or deny it. Of course, 1 gram diluted in 100 ml, normal saline over 10 minutes. Pediatric dose is going to be 10 milligrams per kilo, same 100. Some assessment findings here. We have epistaxis, hemoptysis, that's coughing up that blood. Hematemesis is vomiting. Hematochezia is stool in the blood, and melena is going to be the dark tarry stool. So these are both, these right here are both going to be blood in the stool, but one's going to be more bright, and then one's going to be very dark. Different types of shock, hypovolemic, most common, loss of any bodily fluids or blood. Here's that. Cardiogenic is just going to be a shit pump. Your heart's failing. Neurogenic, which is a pretty interesting one. You're going to have a disruption within that communication pathway in your central nervous system to where on the kidneys where you have your adrenal cortex, there's going to be a loss of sympathetic tone, so you're not actually going to be able to release or properly conduct your epi, norepi to go throughout your body. So it's not even there. So you're going to see things like right out the gate, hypotension, bradycardia. Not much we can do because even if we deliver that epi, you don't have that sympathetic tone, so it's not going to be properly distributed throughout the body. Anaphylaxis, this is pretty. This is one we should probably know very well. It's going to be caused from degranulation from our basophils and our mast cells that will also give a release of histamine, which will vasodilate, increase capillary permeability, bronchoconstriction, contraction of the gut. Yep, there's our permeability. We're going to have that fluid shift. Yeah. Funny enough, so if you're thinking of why contraction of the gut, there's actually H2 receptors, histamine 2 receptors found in the gut itself. So yeah, septic shock. Here is our sepsis alert here. I don't think I put. Yeah, no leukocytosis. Oh, here it is. I didn't write it down, but platelet count above 100K. Here's our basic criteria. If we do our trauma, we should all know these. This is a couple of years ago. This is the way I believe it should be done. I hate how they're shortening up, but you have your IRC, impression, responsiveness, chief complaint, ABVO, any injuries, circulation, BPS for skin color, shock management, and then this stuff pretty much stays the same, just a head to toe assessment. Pelvis and femur, just get ready to move. Scalp can bleed a lot. There's just so much vasculature, and it actually does not have a vasospasm mechanic. This is just so blood up in your head can just, with gravity, go back down to the heart. We have our obstructive shocks. We have our tension. This can be just increase in intrathoracic pressure where that tension actually obstructs onto the heart, and you'll have tracheal deviation. This can be actually contralateral to the side, so we have our fucked up lung here. It's going to be kind of like pointing down to the lung if our trachea is up here. Subcutaneous emphysema, asymmetrical chest movement, hyperinflated chest just due to that increase in pressure. Pericardial tamponade, this is going to be fluid within the sac of the pericardium. There's going to be so much fluid that's surrounding the heart that it cannot properly function with our Starling's law, so the bigger the stretch, big contraction. So you'll see things like JVD, Beck's triad, muffled heart tones, tachycardia, decreased cardiac output, low QRS voltage, and possibly electrical alternans. If you see any of this, if you have a patient with electrical or pericardial tamponade, please send me an EKG. I'm begging you. Some things that we can see for internal hemorrhaging is colons and Gray Turner sign colon. If you think two C's like Chanel, you put colon and colon together, creates a little circle. You can think of that as your belly button, so that's going to be that periumbilicus ecchymosis. And then Gray Turner's, think of thoracic cavity or your T5 or whatever. This can be retroperitoneal on your back, hemorrhaging. Epidemesis, hematochezia, rectum bleeding, melena, dizzy while standing. That's going to be that. Orthostatic hypotension, narrowing pulse pressures, increased heart rate, of course, indicative of shock, weakening pulses. If you need a review on pulse pressures, I got you. So let's say we have 120/80. It's actually just going to be the difference of these systolic and diastolic. So if you have a pulse pressure of 40, that is the normal. But let's say we have 140/125, pulse pressure of 15, and you're suspecting internal hemorrhaging. Pulse pressure of 15 should kind of give it away to you. I wouldn't deem your assessment finding on it, but just know all these things can happen. You put them all together and you say, hey, listen, doc, this is what I got. Look at the pulse pressure even. Something to look at. Ask about blood thinners. Of course, they will inhibit the clotting. Beta blockers will inhibit your beta receptors, so it'll inhibit your tachycardia. So yeah, if we have neck wounds or chest wounds, stuff like that, occlusive dressings. Yeah, if you do have a head injury and you do have CSF leaking, leave it, let it leak. The reason why this happens is or why we should keep it from happening is this will actually lower our ICP. So if we were to plug that up, we're going to raise it farther, and our patient condition will just go right out the fucking window. So yeah, that's going to be the first 3 chapters here. I think I have plenty more to come. So yeah, that's just about the tip of the iceberg here. So yeah, go ahead and go back, or if you guys need me to go over anything else within these first 3 chapters, go ahead and send me an email or a message or text or whatever it may be, and I'll see you guys in the next one. Peace.